Thanks for joining us. So I'm Jay Shepherd. I'm your host this evening. This evening's talk is by the one, the only, the amazing Dr. Anna Crown, who is consultant endocrinologist at Royal Sussex County Hospital and also honorary clinical senior lecturer at Brighton and Sussex Medical School. You're in for an absolute treat this evening, folks. If I just run through some housekeeping, if you'd like to keep your cameras on, we would encourage you to. We want to see those beautiful faces. But please do stay on mute. Any questions, please put the questions in the chat, and then I will relay them to Anna in the Q&A session after the presentation. You can use the closed captions facility by clicking on the CC button at the bottom of the screen. Whether those closed captions decipher this very thick Welsh accent remains to be seen, but you can try by all means. This session is going to be recorded, but not the Q&A session. And this is a really important aspect of the session. Answers to questions can't be used as specific advice, and I will try and answer the questions to the best of her ability, but she obviously doesn't know your medical history, so you would still need to speak to your own doctor and your endocrinology team. So without further ado, I would like to hand you over to the amazing Dr. Anna Crown.
Well, thank you very much. What a very lovely introduction. And thank you very much for organising this session and for inviting me to talk. So it's a slightly different sort of topic, but it was a topic that the Pituitary Foundation felt hadn't been covered in other talks, and it covers a sort of mix of pituitary conditions within the overarching theme of cystic pituitary lesions. You'll find I'm also going to include some sort of basic background about pituitaries, so hopefully it will be interesting even for those of you who have a different type of pituitary problem. You'll still maybe get something out of joining this session this evening. So I thought we should start with this term lesion. So lesion is a term that as doctors we use a lot, and I think sometimes we forget that it's not really a common term that people use day to day. And all it means is an area of abnormal tissue. So it's not really telling you very much at all, apart from something's there that typically shouldn't be there. So it doesn't tell you if something is benign or malignant. It doesn't tell you specifically what the diagnosis or the actual nature of the issue is. So sometimes it's used because we've made an initial finding, we can't quite be sure what that implies, but when one uses the term cystic pituitary lesion, that's all that the term lesion actually means. Next slide, thank you. So what are called cystic pituitary lesions, as in something in the pituitary that looks a bit cystic, and cystic is exactly the same as common parlance, are often what are called incidental findings. So again, the term incidental finding means that somebody didn't present with symptoms and you then did a scan and said, well, this is the cause of your symptoms. They've had a scan for another reason. So for example, they may have presented with a headache or with a seizure, and they have an MRI brain scan and they find a cystic pituitary lesion on that scan. So very frequently when they're detected, these lesions by definition are not causing any symptoms. And nowadays it's much, much easier to get an MRI scan than it used to be. Even, sort of when I started training, we do a lot more MRI imaging. And the MRI scans that we carry out are far better quality. You get higher resolution, if you imagine, almost like more pixels. So you see things now that previously would never have been even noted, things that are, much less than a centimetre, often only a few millimetres, can be picked up. Where previously, to be honest, people would have lived their lives with these things, never known about them, never worried about them. I think the problem is once things are found, then generally speaking, it is recommended that there's a bit of assessment to work out, well, what is going on? What's the diagnosis? What is this cystic thing that we've spotted? Does this patient need any further investigations to look into this, and we'll think a bit about what kind of investigations might be recommended. And then, you know, to say, well, what needs to happen next? Is this something that actually needs treatment now? Is it something that needs surveillance? Or sometimes is it something that can be just, you know, sort of put to bed, something that's been found but doesn't need either treatment or surveillance? So that gives you a bit of background as to how a lot of these so-called cystic pituitary lesions are actually discovered. Next slide, thank you. So in terms of an overview of what different kind of conditions fall within this category of cystic pituitary lesions. So pituitary adenomas, which are the benign pituitary growths that you'll have heard a lot about, some of you may have those or have a friend or relative who has one, they can be cystic. So sometimes they're solid or sometimes they have a cystic component to them. And the other thing that can happen with pituitary adenomas is you can sometimes get what's called an occult hemorrhage, as in a very little bleed into an adenoma, and a little bleed on a scan will also look like a little cyst. And this is not pituitary apoplexy that some of you may have heard about, which is a kind of major hemorrhage into a pituitary adenoma. It's something much more slight and again, often not really symptomatic. So sometimes people have a pituitary adenoma that has a bit of a cystic component, and that's one type of cystic pituitary lesion. Because pituitary adenomas have been the focus of quite a lot of other Pituitary Foundation talks, I'm not going to kind of dwell on those or cover them further this evening. So other cystic pituitary lesions, which I'm going to talk a bit more about. So there are craniopharyngiomas, quite a long word, we'll talk a bit more about them. Rathke cleft cysts, and again, I'm sorry, they're all tongue twisters basically, but we'll talk a bit more about them as well. Arachnoid cysts, and then we'll just cover what's meant by this term empty sella, which again, some of you may or may not have heard about. Fundamentally, when these cystic pituitary lesions are spotted on a scan, they do have different features on the MRI imaging. And you'll be aware that MRI imaging often involves injection of a contrast medium, typically gadolinium, and that can also be helpful in working out what's going on. And we're very dependent in endocrinology of our specialist neuroradiologists. So we all work together now in what's called multidisciplinary teams, or MDTs. And essentially what that means is that we'll have a meeting typically, you know, once a week or once a fortnight. We'll look at the scans with our neuroradiologists, with the endocrinologists, with the surgeons, sometimes with the radiotherapists as well, and, you know, discuss the scans. What are we actually looking at? Sometimes when you have your first scan, the diagnosis is not totally clear. You can be generally reassuring, it doesn't look worrisome, but you can't say exactly which of these diagnoses applies. So then often what we'll do is we'll do an interval scan. So we'll repeat the scan at a certain interval, maybe 6 months, maybe 12 months. And sometimes that kind of surveillance can help you reach a diagnosis. So for example, a small bleed will resolve into a small blood clot, like a bruise does the same sort of thing. So if you look at that sequentially, then that diagnosis can become clearer with time. Next slide, thank you. So in terms of what I'm going to cover, as I said, I'm going to give you a little bit of background because it will help, I think, to understand the topics we're covering. And that's going to be a bit of anatomy. So anatomy is the structures in the brain, a little bit of embryology. So embryology is how things are formed in the womb, you know, how we develop in the womb, and a bit of physiology. Physiology is function, so function of the gland. We'll think a bit about what the consequences of these cystic pituitary lesions might be, what effects they might have on somebody's health. And then, as I say, I'll just run through those specific lesions I've talked about in a bit more detail. Thank you. So that we'll start off with the basic science. Thank you. So anatomy, and you know, obviously there's not going to be a quiz on this, don't worry, so it's just for your interest. But what you can see in this picture is the pituitary gland, blobbing down there. You can see that we talk about two parts of the pituitary, the anterior pituitary and the posterior pituitary. What you can see also in that scan is that the infundibulum is sometimes called the pituitary stalk. So the stalk is the bit that connects the pituitary to the hypothalamus. The hypothalamus, the gland you can see at the top there, is actually part of the brain. So the stalk's connecting the pituitary to the hypothalamus, which is part of the brain. And you can see there some important sort of anatomical relationships. So I'm sure you're aware that if pituitaries develop problems. Sometimes they can affect your vision. And that's because the optic chiasm, which is where the nerves from the eye go back to the brain and they cross over at the chiasm, sits just above your pituitary gland. So you can see that there's not too much space there. If something enlarges in the pituitary, it can then cause some pressure on the optic chiasm. The other thing you can see there is that the pituitary sits in a little bony dish. So it sits in a little bony dish within the skull. And that's sometimes called the sella turcica. So it's within the sphenoid bone. A normal pituitary just sits within that little dish, but if a pituitary enlarges, it can grow up out of that sella. And that's sometimes called suprasellar extension, as in extending upwards out of the sella, and that's when it can cause problems with your vision. So that's just an introduction that I'm sure many of you are maybe familiar with already in terms of the pituitary, its anatomy, where it sits, and what structures sit around it. Next slide, thank you. This looks very, very complicated, and as I say, definitely no quizzes, but we have to really respect our surgeons here, because you can see what a very busy area the pituitary is. So either side of the pituitary gland, those orangey yellow, depending what colour they look to you, but orangey yellow circles are your carotid arteries. Now, these are very, very important, key to, obviously life and health. So when our surgeons are doing any sort of surgery, obviously they have to be very wary that you've got that as a very close anatomical relationship, either side of your pituitary gland. And also within the sinus that sits either side of the pituitary gland, you've got important cranial nerves. These are nerves that supply different aspects of the face. What you can also see there just above the pituitary gland, and it's labelled diaphragma sellae. So that's basically a sort of tough layer of lining, almost like very tough cling film, that goes over the top of the pituitary fossa. It's part of the meninges, which, as I say, you can kind of imagine like the cling film around the brain. And that typically sits on top of the pituitary gland with just a little gap that the stalk goes through, as I say, to go up to the brain and the hypothalamus. So that's, again, just giving you those sort of anatomical relationships. Again, you can see the optic chiasm there. You can see that if your pituitary develops any swellings and grows upwards out of that little bony dish, then it's going to potentially press onto the chiasm and cause visual problems. Great, thank you. Next slide. So this is just looking at your skull slightly differently. So this is cutting your skull across the middle with your eyes at the front and then the back of the brain at the back. So this is really just to show how the vision works. So you've got your nerves going from the retina at the back of the eye into the optic nerves, and then that chiasm is that crossroad structure, that bit in the middle that's labelled there, which is the bit that we said sits just above your pituitary gland. You can see it's a crossing over of those highways, the nerve fibres, before they go back to the brain, and obviously the brain is where all those signals are interpreted into vision. And you may have heard the term bitemporal hemianopia. So those of you who are really into your sort of physics, I guess it is, can see that if you look at those, the way that diagram is drawn, the bits in pink are the bits that are going to give you your right visual field. The bits in blue are going to be the bits that will give you your left visual field. Now, if you have a pituitary problem, it presses up right in the middle of the chiasm. So the bits it picks off actually affect your lateral vision in both eyes. So that's, again, anatomically explains the sort of visual effect of growths on the pituitary gland, be they cystic or be they adenomatous or other sorts of things. It's just because of the way those nerve fibres cross over at the chiasm is why you get that very specific effect on vision. So embryology, and this is, as I say, how we develop when we're in the womb, how the brain develops, and this is specifically how the pituitary develops. So the pituitary develops from two sort of outpouchings, a top-down one and a bottom-up one. So the top-down one, the diencephalon, that sort of primitive brain. And the bottom-up one, Rathke's pouch, is actually pouching out of the bit that becomes the roof of the mouth. And the reason I show this is partly you can then see that the sort of top-down bit becomes what your posterior pituitary, the bottom-up bit becomes your anterior pituitary, and obviously they stick together. But you can get left with a little remnant of that Rathke pouch. So the remnant, as in it doesn't sort of die away, and the remnant can become what's called a Rathke cleft cyst, which is one of the conditions that we're going to talk about. So you can almost imagine you might be left with a little cyst sitting between those anterior and posterior bits of your pituitary, just through the way you develop in the womb, if you're just left with almost like a little outpouching between those two parts of your pituitary gland. Next slide, thank you. So this is just MRI scans, just to give you an idea of what Rathke cleft cysts look like when you scan somebody's head. Can you see my arrow if I move my arrow, Jay, or not? Maybe not, because no, sorry, because you're in control. Sorry. So basically, yes, right in the middle, down a little bit. It's like one of those quiz shows. There's a circular bit, just right in the middle, up, 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 up. Yes, up a little bit more. Yeah, that circle there that you've just about reached. Yeah, so that's a little Rathke cleft cyst. And then the kind of bit that looks like a flat hat on top of it, that's the optic chiasm, the bit that looks like a flat cap. So you can see there that if that cyst becomes bigger, it is actually going to start pressing on the optic chiasm, which is running over the top there. So this just gives you an indicator, again, what these cysts would look like on a scan. And again, it shows you those sort of anatomical relationships, but this time in the form of an MRI scan. Good, let's go on to the next slide. So this is what we were talking about, the effect of larger pituitary problems on the vision, and this thing that's called bitemporal hemianopia. So these medical terms are a bit of a nightmare, but if you unpick them, so hemianopia means that you can't see half of the visual field. So half of the visual field that you should be seeing, you can't see. These are the types of tests where I'm sure you'll have all had them done at an ophthalmologist or at an optician's, where you're told to look straight ahead at a central light, and then tiny little red lights flicker around, and you have to click on a clicker each time you see that tiny little red light. And what they're checking there is your peripheral vision. So they want you to look straight ahead, but they're saying, what can you see if you're just sort of looking around but fixating centrally? And the black bits are what the person can't see, and the sort of lighter white or grey bits are what somebody can see. So in that bottom figure, that's a really complete bitemporal hemianopia. Sometimes it's tunnel vision, so they're really missing both of the outer parts of their visual field. And as I say, when we looked at those diagrams of where the optic nerves go through the brain, you can kind of understand why that might happen. The top picture is somebody who's less severely affected. So there's a little bit of loss of vision there, and you can see those upper outer fields are less good than they should be, with that sort of black area, the bits the person can't see, but obviously not as severe as the lower diagram where they're really missing literally half of the field. And because the nerves cross over like that, it is very precise and really quite mathematical when it's full. You know, literally you cross the midline and you're seeing fine, and you cross the midline the other way and you can't see things. So this is the visual field defect that you typically get from a pituitary problem that's pressing up on your optic chiasm. Thank you. Next slide. So physiology is function. So this is not to do with what things look like, it's to do with how things are working. And again, I'm sure many of you will be familiar with the different hormones because you'll have had blood tests measuring these various different hormones. But your anterior and posterior pituitaries make different hormones, and they all have different functions. So just briefly to run through them, and again, you know, it's not intended that this is any type of a quiz, but just for interest. So the anterior pituitary is making ACTH, and ACTH is the hormone that stimulates the release of cortisol. So that's regulating that axis. The anterior pituitary is also making the hormone TSH, or thyroid stimulating hormone, that regulates your thyroid axis. The anterior pituitary is making the hormones LH and FSH, and they're the hormones that regulate your gonadal axis. So when we say that, that's to do with ovaries and testes and their hormone production, estrogen and testosterone, but also to do with fertility, as in eggs and sperm. Anterior pituitary makes growth hormone. Growth hormone stimulates the production of IGF-1 from the liver, so that's another of these so-called axes. And the anterior pituitary also makes prolactin, a hormone important for lactation. So those are all anterior pituitary hormones. And your posterior pituitary to be very picky, the posterior pituitary is releasing hormones that are actually made in the hypothalamus. So you remember the hypothalamus was that gland at the base of the brain. And so these are hormones that are made in, excuse me, the hypothalamus. They travel down that stalk and they're released from the posterior pituitary. And those hormones include AVP, which is an antidiuretic hormone. This is important for our salt and water balance, so regulating thirst and urination. And also oxytocin, which is a hormone that has some roles in lactation and breast milk release. So that's just an overview, and many of you will be familiar with some of these because you'll have had so-called pituitary profile blood tests taken. So hypopituitarism is thus the condition where the pituitary is not working properly, and that can be the result of these cystic pituitary lesions or other pituitary problems, or it can be the result of treatment for pituitary problems. So you may lose the function of the anterior pituitary and those hormones. So secondary just means that the problem is arising from the hypothalamus or pituitary rather than, for example, the adrenal gland or the thyroid gland. So secondary hypoadrenalism results in low cortisol levels. Secondary hypothyroidism, and hypo just means underactive, results in low thyroid hormone levels. Hypogonadism means that you're not making sufficient estrogen or testosterone, and that can affect also fertility. And growth hormone deficiency results obviously from insufficient growth hormone production. So as I say, hypo means too little. Secondary just means this is a problem arising in the pituitary or hypothalamus. From the posterior point of view, you may end up with what used to be called diabetes insipidus, but we now call AVP deficiency. And symptomatically, what that results in is excessive production of very dilute urine and excessive thirst. Now, all of these pituitary deficiencies can be treated with hormone replacement, and some of you may be on replacement for some or all of these axes. But this can be a consequence of some of these pituitary lesions that we're going to talk about. Thank you. Next slide. And just briefly to talk a bit about the hypothalamus, this gland at the base of the brain, which, as I say, the pituitary is connected to through the stalk. The hypothalamus is really a very critical gland, and you can sort of think about it as integrating information. So it integrates peripheral information, which may be your fat stores, how much food you've eaten, if you've got an infection, if you're stressed, if, you know, heaven forbid, a bus has just run you over. So it integrates all of that information, and it sort of integrates information from the brain and the periphery, and then regulates your pituitary hormones to try either to stabilize things or to sort of rescue a situation. The hypothalamus has critical roles in energy balance, so matching what we eat to the energy that we expend in terms of our resting expenditure and our exercise. It has important roles in sleep and also temperature regulation. So people who have damage to the hypothalamus not only can end up with an underactive pituitary, but they can also end up with other problems specifically related to the hypothalamic damage. Those can include things like weight gain. And typically these people with hypothalamic damage experience an appetite which is greater than normal. They don't get that feeling of fullness when they've eaten. They're always hungry. They can experience sleep disorders, so just dysregulated sort of day-night sleep regulation. And they can experience dysregulation of their temperature control, so just the control of their body temperature is not regulated normally. So those are some of the functions and consequences of damage to the hypothalamus. So now we'll come on to the actual topic of the talk and talk about specifically some of these cystic pituitary lesions. We're going to start with a condition called craniopharyngioma, very long name. So craniopharyngiomas are typically suprasellar. What that means is they originate above the pituitary sella being that little bony dish which we saw, which is where the pituitary sits. Often these are a mixture of solid and cystic, these lesions. They have solid components and they have cystic components. They are benign in the sense that they don't spread to other sites, which is sometimes called metastasizing. So they don't do that, but they can be quite locally invasive and they can infiltrate surrounding tissues. And they can also recur. So once they've been resected, they can come back again. So although they're benign, they have some features that are slightly different to a typical pituitary adenoma in the way that they behave locally. Craniopharyngiomas are rare. There are two sort of peak ages when they may present. One is in childhood, and I've put there sort of roughly 5 to 14 years of age, and the other is in adulthood and sort of middle age. And again, I can only apologise for these very long names, but there are two different types of craniopharyngioma. And one of them is adenantinomatous. We will try not to say that too often. And the other is papillary. And researchers are now understanding much more about these tumours through, doing lab-based research and understanding that they arise from different genetic mutations. So they're understanding why there are two different types and why they behave differently. The adenantinomatous ones particularly occur in children and are mostly cystic, and the papillary ones are mostly solid but can be cystic. Next slide, thank you. So in terms of how somebody might present if they have a craniopharyngioma, quite often a craniopharyngioma will present with symptoms at presentation because of where it sits and what it does. And those symptoms may be visual. So we've thought about your vision and that bitemporal hemianopia that people might experience. They may be endocrine as a consequence of hypopituitarism, so the pituitary not working properly, and sometimes diabetes insipidus or AVP deficiency. And craniopharyngiomas can present with headache because they can be sometimes quite sizable. How do we diagnose them? So the MRI scan, as we've said, is vital. Slightly unusually, often a CT head scan is also helpful with craniopharyngiomas because CT scans can show where there's evidence of calcification, and that can help with differentiating these tumours from other types of cystic pituitary lesions. Obviously, patients will have a formal endocrine assessment, that's the pituitary profile blood testing we were talking about, and a visual assessment with the ophthalmologist, and that will include assessment of their visual fields, again, that we've talked about. Treatment for craniopharyngiomas is very specialist, and it's not even really something that happens in most endocrine centres apart from the most specialist centres. And it really is critical that you have MDT decision making, that multidisciplinary team, because these are fairly complex to treat and you need to get the right decisions in the right hands. Surgery, so sometimes the surgery will be transsphenoidal, which is the route up through the nose and through the sinus, which is most typically used for pituitary lesions. But sometimes, because these can be bigger and, as I say, above the sella, patients need a craniotomy, which is neurosurgery where you actually cut through the skull itself. Patients may need radiotherapy, and there's different types of radiotherapy, which I won't go into, but different options. And the aim of the radiotherapy often is to reduce the risk of recurrence, to reduce the risk of this coming back once it's been resected. And I'll briefly mention there are some new, very, very new and emerging what are called targeted therapies. These are not yet standard care, but I thought people might be interested just to hear about some new research developments. With craniopharyngiomas, and again, this is different to other pituitary adenomas, it is often not feasible or even advisable to try to remove them completely. And I know that might sound a bit counterintuitive that you have surgery and the surgeon deliberately leaves some of it behind. But what they have to factor in is the potential damage to surrounding structures. And we've seen what a busy area it is around the pituitary. And they don't want to damage areas of the brain nearby that are really very critical. So they're going to be balancing what they do very, very carefully. And that's why it's such a very specialist area. And patients with craniopharyngiomas typically need really lifelong follow-up. And they'll be followed up within neurosurgery, within neuro-oncology, within endocrinology, and within ophthalmology, because these, as I say, do have a certain risk of coming back or of progressing. Thank you. So possible complications of craniopharyngiomas and the treatment, so hypopituitarism, which we've talked about, that can be treated with hormone therapies that many of you will be familiar with. The diabetes insipidus or AVP deficiency can be treated again with hormone therapies, desmopressin. Sometimes people don't feel thirsty. That's very difficult to manage because you have to be sort of measuring how much you're taking in, how much you're weeing. You have to be checking, particularly in children, on the actual weight. So impaired sensation of thirst is a very tricky thing to manage. And the weight gain that we talked about, this excess appetite, this not feeling full, is also really tricky to manage. Some of the newer options, and again, these injectable treatments that, again, people will have heard about in the context of treatment for obesity, can be a helpful treatment option in this case. Sleep disorders and temperature regulation, again, very difficult medically to manage. Often it's a matter of helping people to live with those conditions. So I would say that overall, the craniopharyngioma tends to result in more adverse health or quality of life consequences than most of the more typical pituitary adenomas in their treatment. Now, this doesn't apply to everybody, but in general terms. Thank you. Next slide, please. So I did mention there are some new targeted therapies. Just to stress, these are not yet standard care, but I think it's interesting, and it's always, I think, encouraging for pituitary patients to know about the active research that's ongoing. So some of the papillary craniopharyngiomas have what's called a BRAF mutation. So essentially, this is a genetic mutation that people have started to understand, whereby it increases the proliferation of the cells. So that's how cells multiply. It increases cell survival. So you can see that's not a good thing, because that's going to make things grow. So if that can be diagnosed through a biopsy, so that does mean neurosurgery, then you can have treatment specifically to target that genetic mutation. I've put the names of the drugs there, but it doesn't really matter what they're called. These are very high cost drugs, and it wouldn't be the sole treatment. It would be part of a sort of multimodal treatment, which may also include the other modes of treatment we've talked about, the surgery, the radiotherapy. But people are excited about these, and I think in the future, this sort of targeted genetic treatment may become more available for different types of craniopharyngioma. And people are also excited that it may in the future be possible to look at the MRI features and just circulating DNA, as in a blood test, without actually having to do a neurosurgical biopsy, to make a diagnosis and potentially then recommend the use of one of these drugs. So as I say, this is not yet standard care, but is coming online and is exciting for certain, small at the moment groups of patients who might benefit. Next slide, thank you. I mentioned this very briefly because some of you again may have heard about this. If you have a cystic lesion anywhere in your brain, but also in the pituitary or near the pituitary, you may have something called an Amaya reservoir or shunt. And what that is basically a very fine tube that's linked to a little reservoir just under the scalp there. And that can be used for cysts that tend to reaccumulate. And it means that you can drain that cyst fairly straightforwardly through a needle through the little hole in the skull there, without having to have more neurosurgical intervention. So that's just a subsequent treatment that can sometimes be used, and those can just be left in place for troublesome cysts that reaccumulate. Thank you. Next slide. So I'll move on now to Rathke cleft cysts. So these are much more common. So I've put there how common they are in autopsy. I know it sounds a bit grim, but if you dissect, bodies and brains after people have died, they're very common Rathke cleft cysts, 13 to 33% of the population. So an awful lot of people will have a Rathke cleft cyst and never know about it because it's tiny and they never had a scan. Typically, the peak age of presentation is in middle age, 30 to 50 years, but there's always a variation. Rathke cleft cysts are definitely benign, always benign. In terms of their location, they may be intracellular, as in sitting in that little bony dish where the pituitary is meant to sit. Sometimes they may be supracellular, as in expanding above that cella. They are usually very central, medial, which is centrally located. And as I showed you in that embryology picture, what they're developed from is remnants of that Rathke pouch. So in the embryology, that little bit that should just have disappeared away can sometimes be left. Rathke cleft cysts, in terms of what's in the cyst, it tends to be a slightly what's called a mucoid material, so a mixture of cholesterol and protein, so a slightly thickish kind of material. Quite often, Rathke cleft cysts are discovered by chance, and we talked about this at the beginning. This term incidentaloma is a funny term, but it basically means we weren't looking for anything, the person had no relevant symptoms, but we found this thing when we were doing an MRI scan for another reason. Many Rathke cleft cysts are totally asymptomatic, they have no symptoms whatsoever, but if they're large, they can cause symptoms, and those may be visual, and we've talked about the effect on vision that pituitary problems can have. They may press on the normal pituitary and cause an underactive pituitary gland. They may cause headache only if they're, significantly large. If they are symptomatic, they can be resected, as in surgically operated, but because they are, really very benign, as ever with any type of surgery, you need to weigh up what are the potential risks and what are the potential benefits. So certainly that would not be a recommended course for many people with Rathke cleft cysts, because we know that many of them will stay the same with time and sometimes even get smaller with time. And as with many pituitary things, headache symptoms may or may not be related to the pituitary lesion that you found. And the headache symptom can go away as well, or may never have been related to the Rathke cleft cyst. So again, when people are thinking about surgery, surgeons would never operate saying your headache will go away, because they really can't tell that. They don't know if it was related and they don't know if it will resolve with treatment. But headaches can just go by themselves. Next slide, thank you. So just briefly to run through other cystic pituitary lesions that people may have or may have come across. So you can get something called an arachnoid cyst. So basically this is a collection of CSF, which is your cerebrospinal fluid. That's the fluid that runs all around the brain and spinal cord. And it's basically, you remember we talked about the meninges, these kind of cling film layers that cover the brain. So you've got a bit of the arachnoid membrane that can herniate or pop through that diaphragma celli, which was that roof of the pituitary fossa. So it can just pop in and be filled with CSF. And these are definitely benign, and again, may or may not require any treatment. In terms of surgical treatment options, they can be removed. Sometimes they can then leak, which is tricky. So sometimes they fenestrate, which literally means making little holes in it so the CSF drains away and the cyst becomes smaller. And again, always, any surgeon will always be saying, what are the risks? What are the potential benefits? A CSF leak, which is a leak of spinal fluid, is troublesome. They don't want to cause problems if something is small and asymptomatic, especially, you know, when one knows this is very benign. Next slide, thank you. Empty sella I mentioned because some of you may have heard of this and may even have been worried about it. And I think it's quite important just to understand what's meant by this. It's really a radiological description, and it's slightly an old-fashioned radiological description. So when I say radiological description, it's something people will say, this is what I'm seeing when I'm looking at this scan. What it means is that sella turcica, that bony dish where the pituitary sits, is slightly large, and it's filled with spinal fluid, the CSF. The pituitary tissue is there, but it's just slightly stuck down on the floor of the sella, slightly pushed away to one side. So it's not that the pituitary is absent, it is there, it's just typically just sitting on the floor of the sella. Sometimes people would be left with this appearance called empty sella when they've had successful surgical treatment of a pituitary adenoma, and that's secondary. Sometimes people just have this appearance, nobody really knows why, and it may or may not be associated with any pituitary function whatsoever. So you can have completely normal pituitary function, as in hormone function, despite this appearance of the empty sella. So again, this is something that I think sounds more alarming than it is really, because it sounds like something's missing when it's not really. Thank you. Next slide, please. So I wanted to leave time for questions, which I think we have. So this is what we've talked about. As I say, hopefully gave you a little bit of an overview, which I hope was of general interest in terms of the basic sciences behind pituitaries. And because of understanding that, we could then understand what cystic pituitary lesions can cause. And then we've thought through some of the more common and more rare cystic pituitary lesions that you can get: a cystic pituitary adenoma, the craniopharyngiomas, Rathke cleft cysts, arachnoid cysts, and this empty sella appearance. So I'm more than happy to take questions and discuss anything that anyone would like to discuss in more detail. Thank you.